Okay. Hope you my presentation is shared now in the screen. Can you see it, Hal?
اتفضل يا فندم.
Yeah, we can see the presentation. Yeah.
Yes.
Thank you, Dr. Prasad.
Yeah.
I would like to in what kind of emergency for corneal complications. Think that we have to have the philosophy of saving procedure, eye saving procedure. Severe ectatic condition or uncontrolled corneal subsequence of it. Sometimes in the verses of the Quran, you are obliged to fight, which is something that you don't like. Some of the uncontrolled infection, at the beginning, you are trying to give a chance for the medical, topical, and systemic medication, and you are hoping that this can subside, and you can go out with the case winning. But unfortunately, sometimes not. You have a patient like this in the outpatient clinic coming to see you, and he says something went out of my eye, and this is how it looks and you are sitting in your clinic in the center of Cairo, and you don't know what to do. And this is another case. Somebody have giving this patient a chance with amniotic membrane, and still it's not working. So some cases are simple, like in lag of Salmos, there's a tiny perforation. Either you try with contact lens. If it fails, you go for tectonic graft and simple fashioned graft. You fashion a small graft, because normally the rest of the cornea is healthy, and you can fashion a small graft like this, and you have it after treating the cause, of course, of the lag of Salmos itself, and you suture it, and normally it went okay if you treat the primary cause. And some patients are lucky that, like this patient, you find a small graft of a previous keratoconus patient, and surprisingly, this patient is seeing 0.3, and actually we didn't do anything else for her. But not all cases are simple. In rheumatoid patients, the melting is very severe, and you have to go for more extensive surgery. Like in this case, we found that the lens itself is not there. So vitreous is coming out through this small, tiny perforated melted cornea. And you have to aggressively clean up everything, and then suture a graft, fashion and suture a graft. But you have to clean all the edges and the median. And this is how we fashion the graft. And at the end, the patient is getting well. In a case like this, this is a disaster. A patient had bilateral ICL, which is completely against the law here in Egypt. She's having a low hygiene and low socioeconomic standard, and used to be contact lens wearer before. Her surgeon applied to her steroids as usual from day one, but he didn't notice that there is some kind of tiny infection. And when she called him by second day, he gave her more steroids even, and he said that this is just a reaction. I don't think it looks like cash. And the patient came with left eye melted. And you have to go for therapeutic graft. In a case like this, you have to remove all the cornea and pray that it will escape from endophthalmitis. In a case like this, the patient had a golden Hare syndrome, a pediatric patient, and for some reason, the lens is opened. I don't know how it comes. It seems that her doctor tried to do her iridectomy, and he touched the lens, and we found lens particle in the anterior chamber. So I had to go for everything. This is how it looks, the Rheumatoid from inside, and then I removed all the lens particle and cleaned the lens, and I kept the posterior capsule intact. And this is a part of a tectonic graft taken from an eye from the patient of that just performed keratoplasty, and we fashioned this tectonic graft just to save the eye because the pressure went up, and the approach was very difficult having this dermoid cyst in front of you. So you go for suturing. Part of the graft is in the sclera, of course, and part in the cornea. And this is how it looks at the end of the surgery. Surprisingly, after a few months, the patient developed clear cornea. And as you notice, the limbus only was opacified. And I didn't have to do her a complete keratoplasty, just posterior capsulotomy and lens implantation. And the patient went well with this. This is another kind of emergency, severe anterior staphyloma. You don't have a catalog for a patient like this or a user manual. How the steps? There is no steps for this kind of operation. You go with surgery, freehand keratoplasty. You go for just removing all the ectatic part of the cornea, heavily vascularized, of course. Peripheral anterior synechia, always blood. You apply the simple maneuver of 0.01 epinephrine, and then you go for lens removal because there is anterior capsular cataract. And I don't want even to go in for this patient again. Remove all synechia as much as you can. Apply the intraocular lens. Suture the iris in order to not to have pupilloplasty, in order not to have again peripheral anterior synechia. Manipulate the IOL inside. Centralize as much as you can. As you can see, as much as you are centralizing the IOL, sometimes it gets out, but at least you are trying again and again until you have the IOL well centered, and then suture the graft. These kind of surgeries, rewarding in spite that you don't have a special step-by-step patient, and this is how it looked in the inside the bag. Thank you very much for hosting the Egyptian Society of Ophthalmology in your schedule. And once again, we thank the All India, and we are looking forward to make mutual